then if I do that, then we can just put up our slides.
Yeah, now I see your desktop.
Okay, so we're just, our slides are on the bottom there?
Oh, yeah, okay.
Yeah, so now everybody that's on will see your desktop.
Go to, oh no, that's your inbox.
Okay,
You have to open it up.
Wait just a second, I'm going to open it up. So computer. Oh, yeah.
Continue.
Continue. I don't care about writing.
There you go.
There. So can you see that?
Yes.
Okay.
Oh, perfect.
Got this. Okay. Do you want me to make it?
Yep, just make it, just make the
Slideshow?
presentation at the bottom there. The, that little button, little slideshow button.
Oh, yeah. Yeah, I'm not used to this. I'm used to the old, the old version of this. Okay. So you're fine on your end? You can see it?
I can see it.
I can see it too.
Okay, great.
So it's funny, it was actually this exact date last year that we did our last presentation, so time flies.
Right on schedule.
Yeah, this is January 9th, 2014.
Was it as cold then?
I can't remember.
We're in a deep freeze here, by the way, so I almost didn't make it in. It was like minus, what was it last night?
With the wind chill, it was minus 8
Last
Celsius.
Well, it did dip to under 40 here in Tampa, which is quite an ordeal.
40 Fahrenheit.
Yeah.
That's Fahrenheit, yeah.
Uh,
That doesn't even qualify here.
that's balmy.
Some people won't even leave their houses here this morning.
Oh, my God.
I could barely get my car started.
You know what? This is what it really is nice to have a heated garage.
Yeah.
So we have radiant heat on the floor.
No, that's good for your car.
So my husband just turns it, like, not up far, but just enough so that when I get in the car, it's like...
I used to have to put a halogen light underneath the oil pan at night to keep it warm enough to start the next day.
Yeah. Oh, yeah. You're wondering about bringing them back? I didn't, but I don't know how to do this finally the other
Yeah,
day.
that's what we did last time.
Couldn't figure it out. After all these teleconference bits, honestly, I figured out how to do it. January 21st.
I'm not going to be here.
I really do need a... Where's everybody?
Yeah, we're still waiting. There's a couple of us here. And I think Dan should be on this morning. Susan, I don't know if you've heard otherwise.
I didn't hear otherwise.
Yeah.
I was speaking to him last night, but he didn't say anything that he wouldn't be.
Yeah. But usually we get started, around 9, 10 or so is when everybody kind of, is when we reach a critical mass. So.
Okay.
But if you guys have any pressing issues with time, we can get started whenever you're ready.
No, we should be okay. We only have one case, so
Okay.
It probably won't take a full hour anyway.
All right. Very well.
Last time I tried to get 3 and it was a bit too much.
Yeah. Turkish Airways. Air India? Ooh, I don't know. Air Canada, that's pretty good. To Mumbai and back, 4,100, business class.
Mm-hmm.
That's not bad.
It's an Indian airline.
No, this is only Air Canada. Yeah, I'm not flying jet air. I don't feel comfortable. I'll stay with Star Alliance. I want big airline.
Yeah, it's not Star Alliance.
Oh, this is really good. That's probably going through Munich, right? Ottawa? Toronto. No. Toronto.
The second largest airline.
That makes me feel much more confident. I don't think safety's always the number one.
Well, they lost money last year. They lost 2.2 billion.
Landing in, I don't know if
Local reports too that transcripts of this guy back in the trial in 2000 that he was convicted in 2008. That initially he had wanted to actually target Jewish targets in France, but had been convinced by a radical cleric to actually focus. Right. This is we've seen those reports as well in French media. The magazine yesterday and what happened in the Boston bombing in the United States. It took some time for you to figure out who your suspects were.
Hello, everybody. This is Janelle in Dr. Harrison's office. If you could remember to self-mute your microphone if you're not speaking, that'll eliminate the background noise.
Press already sent information about these two guys to the U.S. to see what they had on them, and that's what they've been doing the last day, and so they've been trying to figure out basically a map of where all their contacts is in this attack, and whether or not anybody knew about it beforehand.
My name's Jeff Sulpher. I'm a cardiac oncology fellow at the Ottawa Hospital Cancer Centre. I'm here with Susan Dent. And we have a case to present this morning, which is actually an active case. So I thought we'd maybe treat this a bit like multidisciplinary rounds. So I'll just advance the slides here. So the main topic of this is VEGF versus mTOR inhibition in the setting of dilated cardiomyopathy. So that's the clinical issue that we'll be exploring. So our case involves a 67-year-old male who presented with a renal cell carcinoma. And his initial staging was negative for metastatic disease, and he underwent a nephrectomy in mid-August of 2013. The pathology report revealed a 10.5 centimeter clear cell renal cell carcinoma, high grade, and 9 retroperitoneal lymph nodes were removed and all were negative. He has a past medical history of COPD and has an extensive history of smoking. He quit about 2 months before his operation. And he also has dyslipidemia. Now, the backstory is that at the time of his renal cell carcinoma diagnosis, he was experiencing episodes of dyspnea and was assessed in the emergency room where he was found to have congestive heart failure. He was having paroxysmal nocturnal dyspnea and quite severe lower extremity edema. And this was his first presentation. So in the emergency room, a chest x-ray was performed which revealed bilateral pleural effusions, and he had an urgent transthoracic echocardiogram at that time. This showed moderate dilation of the left ventricle and severe global hypokinesis. And his LV ejection fraction was estimated to be 20%. At this point, he underwent a series of investigations to try to figure out what was going on. So here is his initial ECG, which showed sinus tachycardia and some nonspecific ST and T wave abnormalities. I'll just mention, if anyone has any questions or would like to clarify any of the clinical issues, please stop me and we can discuss as we go. The patient went on to have a percentine myoview, which was negative for ischemia by ST segment criteria. The patient wasn't having any chest pain. He also had a normal perfusion at rest and following stress. It was decided not to proceed with an angiogram for whatever reason, and it was felt that his dilated cardiomyopathy was non-ischemic. The etiology, though, still remained unclear. I should mention there was no significant history of diabetes or heavy alcohol consumption. He was initiated on medical management, so he was put on a beta blocker, an ACE inhibitor, a statin. He was put on aspirin. He was put on Lasix for the control of the edema, and his fluid status improved significantly, and he was also put on a nitro patch. He had almost complete resolution of his clinical symptoms, and a repeat echocardiogram performed the following year showed an ejection fraction improved to 38.7%, and he was clinically stable. However, from his cancer perspective, he had a follow-up CT abdomen which showed suspicious new lymphadenopathy in several areas, as well as the psoas muscle mass, and this was all confirmed to be recurrent metastatic renal cell carcinoma. So the question at this point was what the optimal therapy would be for his renal cell carcinoma. And of course, this choice, looking specifically at the cancer, is driven by prognosis. And so good prognosis patients are usually offered first-line vascular endothelial growth factor inhibitors. And there's a few examples here, including sunitinib, pazopanib, and a newer one named axitinib. In patients with poor prognosis, they often go on to receive mTOR inhibitors first. And in Canada, two options that we have are temsirolimus or a sister drug everolimus. And just to remind everyone of the pathways involved with renal cell carcinoma, VEGF inhibitors basically inhibit the VEGF receptors, which prevent the process of angiogenesis, and that's the whole basis of this therapy. mTOR inhibitors do a very similar thing, but they go down a subsidiary pathway, the mTOR pathway, which inhibits this molecule named hypoxia-inducible factor, which inhibits downstream angiogenesis. Here's a few examples of VEGF inhibitors in common use. So in renal cell, likely these two are the first-line options here, sunitinib and pazopanib. And both have been studied extensively in renal cell carcinoma. Here's a schematic of the inhibition pathway. So these are tyrosine kinase, these are small molecule tyrosine kinase inhibitors. So they do have a lot of toxicity associated with them, and one of the main ones is hypertension combined with proteinuria. There is some evidence for LVEF decline, especially in the initial trials. There's also a risk of arterial thrombosis, as well as a host of other issues, including diarrhea, hand-foot syndrome, liver dysfunction, nausea and vomiting, and fatigue. This was a paper published in The Lancet in 2007 investigating the hypertension issue, and at doses of approximately 50 milligrams, 4 weeks on, 2 weeks off, about half of patients develop hypertension. And the mean maximum increase is around 30 milligrams of mercury systolic. So it's so fairly significant spikes in blood pressure. Some people feel that this may be a marker of efficacy. And in addition, there are known EF drops, even when ACE inhibitors and beta blockers are used to treat the hypertension. I dug this out, actually one of our colleagues dug this out of the supplementary material on one of the big papers looking at the use of pazopanib in the treatment of renal cell carcinoma. And there is certainly a significant risk of LV decline with these drugs. So looking here, about 7% of patients treated with pazopanib can expect a greater than 10% absolute decline in LVEF when compared to baseline. So there are known issues here, and these drugs have not been used for very many years. So a lot of data is still coming out on this. There is also a risk, as mentioned, of arterial thrombosis. This was a meta-analysis published in the Journal of Clinical Oncology, looking at about 10,000 patients receiving either sunitinib or a sister drug, sorafenib. And the overall rate of arterial thrombotic disease was about 1.4%, and the relative risk increase on meta-analysis was about 3. So looking at the lower confidence interval here, these drugs can increase your relative risk of arterial thrombosis by at least 25%, looking at this meta-analysis. So this is a significant problem as well. mTOR inhibitors are a little different, and the side effect profile is a little different, and it's felt that they may be a little more gentle on the heart, and they have less of an issue with hypertension. So the main issue with these are immunosuppression, hyperlipidemia, delayed wound healing, and a few other minor issues, including slight increased risk of lymphoma, various infections, and angioedema. So this patient was initially presented before Christmas at our multidisciplinary cardiac oncology rounds, and the recommendation at that time was to choose the best first-line therapy for the renal cell carcinoma, so either Sutent or sunitinib or pazopanib, as this patient was felt to have a good prognosis when looking specifically at the renal cell carcinoma. It was recommended that he have close follow-up with cardiology after about 2 weeks of therapy, and a MUGA to be arranged about a month after initiation of therapy, as well as referral to the cardiac oncology clinic. This patient was being followed by the Ottawa Heart Institute, but it was felt that some co-management with the cardio oncology clinic may be useful. At this point, I'll stop. Does anyone have any questions about this case or any advice, or would they have done anything differently?
Hi, this is Arti Patel. I work with Dr. Harrison. I'm an advanced imaging fellow.
Hello.
Hi. I had a question in regards to the patient's cardiomyopathy. Was there ever consideration for cardiac MRI?
So that's a good question. We do have that capability here in Ottawa. I couldn't tell from the notes. Unfortunately, this was a bit of a second-hand case presentation because I'm not directly involved with this patient, but it doesn't seem that that was discussed. But that would be a very good idea, and I think that's something that should be considered. And this issue came up last year with our similar cases. For some reason, it seems not to be done routinely. Yeah, and we've only had it here in Ottawa for, I think, a few years, so I think that's a very good point. How do you think that might be useful for helping discover what the etiology might be here?
Well, I think when the initial evaluation is unclear, you're looking for maybe some sort of inflammatory or infiltrative cause, it can help rule those out. And really, I think it can also be another objective measure of ejection fraction in these patients with decreased EF.
Thank you. So, unfortunately, the saga continues with this patient, and we were awaiting approval for treatment with pazopanib, and the patient ended up having a subsequent MUGA. And this revealed an EF of 24%, despite medical optimization. The patient fortunately remains clinically asymptomatic, but is having progressive metastatic disease on repeat staging scans. So he's having enlargement of the psoas muscle mass and enlargement of the lymphadenopathy, and now he's having lower back pain. So this, of course, is making everyone nervous, especially his treating oncologist about the best treatment option. And I'm curious to see what people would recommend for his cancer therapy, whether they would still be comfortable proceeding with pazopanib, so the VEGF inhibitor, or abandoning that idea and moving on to an mTOR inhibitor, which may be the inferior treatment for the cancer. I'd be interested to see what people's opinions are on that. Yeah, it's a bit of a challenging case, and these drugs are not. I mean, as I said, we don't have a lot of experience long term with these drugs, and so I think that's what's making everyone a bit uncomfortable. I think my perspective with this patient is that overall his prognosis is not good, and his lifespan is likely measured in months to possibly a few years, and so whatever decision is made for his cancer care, I think it will be limited.
I guess my question is, for the cardiologist, with an EF like that of 24% despite medical management, I mean, we can talk about the prognosis from a cancer perspective, but his prognosis from a cardiac perspective also I don't think is great. So what do people feel might be his prognosis from a cardiac perspective, irrespective of his cancer, given that type of cardiac picture?
This is Samir Dadal from Tucson, Arizona. I think, can you hear me?
Yeah.
I think going back to the initial workup, there's a good likelihood that he might have 3 vessel disease, which would give you a false negative nuclear study. The fact that his EF dropped on the same medical management without any intervention kind of also raises the suspicion. So there might be a reversible cardiac cause at this point to improve his LV function. So that would be the first thing I would pursue, to see if there's any, with an angiogram or with a cardiac MRI, whichever is available, and would expedite things. And if there is a reversible cause, and I wouldn't send him for bypass, obviously, given his overall picture. But if there's a stentable LAD or disease, we've had patients that we've stented their left main to help their clinical course along. That might be an option that would help things also. So I don't think that workup is complete yet.
Okay.
Yeah, I think this is Greg Hartledge here in Tampa again, and I agree with that 100%. You know, especially given the sort of the potential precipitation of manifest ischemia with the VEGF inhibitors as well. Also, I think that with the VEGF inhibitors, that from what we know, that for the most part these are reversible cardiomyopathies, that when treatment is either withdrawn if need be or completed, that these people for the most part, obviously based on somewhat limited data overall, but that for the most part they improve. So that would be something that would be reassuring, knowing that he did not have any other underlying cause of heart disease that you would potentially exacerbate, like the coronary disease that Dr. Dadal just outlined.
Yeah, thank you. So I think in this patient, what will probably be looking at then is cardiac MRI first. This patient is being seen urgently next week in the cardio-oncology clinic, and I suspect that that will likely be the next course of action. I had a question about defibrillator use in these sorts of patients, and I'm curious, what would be the recommended life expectancy in a patient before that would be considered? Would you want patients to have a fairly good overall prognosis from cancer, or what would be your criteria?
Can you restate the question? I'm sorry.
So, I mean, my understanding, I'm not a cardiologist, but my understanding is when EFs start to fall below 30%, there's consideration for insertion of a defibrillator in otherwise healthy patients. Do you think that would be something to be considered in this patient, or is it a bit premature?
So they need to have at least a 1-year life expectancy with reasonable quality of life.
Okay.
And then also, notwithstanding that, you have to rule out pretty definitively any reversible causes of the LV dysfunction. So I think that the cardiac MRI, or there are other non-invasive ways, cardiac CTA in the setting of good renal function. I know he's had an nephrectomy, so that may be
yeah, he has creatinine right now of around 200. So
okay, yeah, but I do think that those considerations would probably be limitations in this patient, and it wouldn't be a priority at this point, given his metastatic disease.
Right. So we had bigger fish to fry first, eh?
Absolutely.
Okay. Well, I think that was it. That's a fairly quick case. Certainly one that's causing us a lot of clinical issues here, and I thank everyone for their advice, and I'll certainly be passing that on. It's an active case, so I'll certainly be passing on everyone's advice to this patient's cardiology team. Thank you very much.
I did have a quick question.
Sure.
Did he demonstrate any other side effects from the VEGF therapy, such as hypertension, or is that fairly controlled?
So he hasn't begun this treatment yet. So, because he basically presented with metastatic disease just a few months ago. So he's being considered for treatment of the metastatic disease with these medications, but there's no evidence at this point for adjuvant therapy in metastatic renal cell with these drugs. There may be some evidence soon, but usually these drugs are reserved for the palliative setting, and he hasn't begun treatment yet.
Okay.
I think he should soon, or else the renal cell is going to get out of control. I think it already is, but yeah, thank you for that.
Okay, any other questions or comments from the group?
So the ICD question, he'll fall under the class 3, because it says that you have to have acceptable functional status with a reasonable expectation of survival for at least 1 year. So his functional status will go in there, and that's a class 3 level of evidence C at this point.
Okay.
But no other questions.
Okay, thank you. Well, thank you so much.
Okay. Thank you, guys.
Thank you. Thank you for your time, and this was a great discussion, and we look forward to the follow-up and hope for good news.
Yes, we'll certainly keep you up to date.
At the next case webinar, maybe we'll give you guys an update. Okay.
That would be great.
Okay.
Great, thank you.
Thank you.
All right, stay warm up there.